Hello, welcome to today's webinar, Substance Use Disorders, Appreciating the Challenges of Minority Youth. This webinar is produced in partnership with the ATTC Networking Coordinating Office, AMERSA, and the Adolescent Esport Project by NORC at the University of Chicago. This webinar is a part of the Transitional Age Youth webinar series. I encourage you to sign up for these other titles at the AMERSA, ATTC, or NORC websites. Today's webinar presenters are Dr. Hoover Adger and Dr. Kevin Simon. Dr. Simon is a board-certified psychiatrist completing dual fellowships in child and adolescent psychiatry and addiction medicine at Boston Children's Hospital, Harvard Medical School. Dr. Simon completed a general psychiatry residency in the Department of Psychiatry and Behavioral Sciences at Morehouse School of Medicine after graduating from Southern Illinois University School of Medicine. Dr. Simon has received research support from the American Psychiatric Association, American Academy of Child and Adolescent Psychiatry, NIMH, NIDA, and SAMHSA. Dr. Simon's research and writings on inequity, race, social determinants, and substance use have been published in the New England Journal of Medicine, Health Equity, Health Affairs, Psychiatric Services, Psychiatric Times, Current Psychiatry, and Child and Adolescent Psychiatric Clinics. He regularly presents at national conferences and has been featured on ABC News, Forbes, and NPR. Dr. Adger is a professor of pediatrics at the Johns Hopkins University School of Medicine. His clinical interests include adolescent, young adult medicine, substance use disorders, and children affected by addiction. He was the previous director of adolescent medicine in the Division of General Pediatrics and Adolescent Medicine, and is now a senior fellow member in the newly created Division of Adolescent and Young Adult Medicine. For a decade, he was the director of the HRSA-funded Leadership Education and Adolescent Health Program and was previous director of the Johns Hopkins Substance Use Faculty Development Program. Dr. Adger is the director of the Substance Use Assessment Intervention Team at the Johns Hopkins Hospital Adolescent Program. He is a past deputy director of the White House Office of National Drug Control Policy. His research interests include substance use disorders and health professional education. He is the past president of AMERSA and the National Association for Children of Addiction. Dr. Adger and Simon have no conflicts of interest to disclose. It is my great pleasure to introduce Drs. Hoover Adger and Kevin Simon.
I'd like to start out by reviewing our outline and our objectives for this discussion. What we will attempt to do is to describe the epidemiology of substance use disorders, as well as the impact of substance use disorders on children and families. We will discuss racism as a factor affecting health outcomes, and we will also discuss health disparities and opportunities for enhancing outcomes in the prevention, intervention, and treatment of children and adolescents affected by substance use and substance use disorders. I'm going to start out by sharing with you a clinical case vignette. And this case vignette is actually what brought me to the field of substance use disorders. I think it illustrates many points. This is a case of a 12-year-old young man who I had the pleasure of taking care of, who I inherited from an individual who was leaving the institution. The patient had a long-standing history of type 1 insulin-dependent diabetes. This interesting young man had a history of multiple admissions to the hospital, and despite the fact of his multiple admissions to the hospital, everyone in the institution was enamored by this young man. He was engaging, he was bright, he seemed to have a lot going on for himself. And as his primary care provider, my role, at least I thought in the beginning, was to try to fix him. I've since learned that that is something that I simply cannot do, and it's not my role to fix anybody or anything. This is probably one of the fallacies of the heuristic of the medical model that oftentimes teaches us that when we identify a problem, that is our job to fix it and to fix it right now. But I have learned that the only ones who can actually do that are my patients and or their families. However, my initial assessment of what I needed to do as his primary care provider was that this young man simply did not know enough about his diabetes. So my first intervention with him was to send him and his family off to a 1-week intensive diabetes educational program with the hope that this would be the answer to his problems. That probably lasted for several months. And after that period, he reappeared, readmitted to the hospital again with his blood sugar being out of control. And then after several months, the patient was admitted to the hospital, and now with a new set of symptoms. The patient, rather than having a blood sugar which was extremely high, had a documented blood sugar of less than 20, and the patient had a new set of symptoms. And at this point, the patient was admitted through the emergency department with a seizure. The patient was subsequently seen by neurology, endocrinology, a number of our specialists who all had a number of interesting theories, but none had any answers to the problem. And so, like most individuals who are attempting to take care of patients, when we're a little bit stumped and don't have the answers, we return back to the beginning and take a good patient history. And so what I did at that time was to sit down with the patient, took a complete history, including a family history and a social history, and used my curiosity to learn about the patient as an individual within his community. And through the inquiry, out popped the secret that many individuals had not been aware of, including myself. The secret to this particular young man's problems with his health was that he was diagnosed with diabetes at the age of 2. His mother was the individual who took care of his insulin injections. And the problem was that the mother had this interesting problem of alcohol use disorder. Depending on how intoxicated the mother was and how blurred her vision was, when she pulled up his insulin, she either pulled up too much or too little insulin. And of course, it didn't make any sense to anyone who was taking care of him because no one had sat down with the family to understand the nature of the problem. And so my intervention on behalf of this young man and his family was to, in my role as a pediatrician, intervene with the mother and to assist the mother in getting into treatment for her alcohol use disorder. The interesting thing is that I had the opportunity to care for this young man for an additional 10 years. And then the 10 years that I continued to care for this young man, what I learned was that he had not a single additional admission to the hospital. And when his blood sugar seemed to be a little bit out of control, my intervention was to harken back to the mother to ensure that she had the support network that she needed to ensure her treatment, her sobriety. And this was a lesson to me that probably, unlike this young man, there were several individuals who were simply suffering because individuals did not know enough to manage something which might not have been outwardly visible. So the question that we can ask ourselves is, how common is this as an issue for individuals? And this slide looks at the epidemiology. It's a slide from the Substance Abuse Mental Health Services Administration. And it simply asks the question of how many children and adolescents are affected by family substance use disorder. And what you can see on this slide illustrated is the number of individuals in a year who meet the diagnostic criteria for a substance use disorder. And you see that the total number is somewhere just under 9 million individuals. And there's a gradation so that you can see individuals according to the age brackets. On the bottom picture, you can see that if you look at the parents in households, either one parent or both parent, that it reaches a number of some 7 million individuals where both parents are impaired. So this study, as well as other epidemiological studies, helps to make the point that this is not an uncommon situation. This next slide is from the National Longitudinal Alcohol Epidemiologic Survey. This is a survey which is conducted by the National Institutes of Alcohol Abuse and Alcoholism. And in this study, which is one of the landmark studies, which was published by Bridget Grant in the American Journal of Public Health, what she shows is that there are some 7.4% of adults who meet the DSM diagnostic criteria for an alcohol disorder in the past year. That's the point prevalence. But if one looks at the lifetime prevalence, it's in the neighborhood of 18%. But as she projects these numbers to what it means for children, the study outlines that there are some 9.7 million children who are living in a household with one or more adults who are affected by an alcohol use disorder. And while the study was done under DSM-4, DSM-5, we no longer use abuse, but the numbers are sobering numbers. And what the numbers go on to suggest, as outlined in the article, is that there is 1 out of every 4 children in the United States who are exposed to alcohol use disorders in the family. The article goes on to define this as one of today's major public health problems. It goes on to describe children who oftentimes are exposed to no fault of their own, and who are at times thrust into families and environments that pose extraordinary risks to their immediate and future well-being, and that at times threatens the achievement of their fullest potential. And so, as a pediatrician, I just make the point that when we look at addiction, it really is a pediatric disease. What we see in information coming from the National Institutes on Drug Abuse, that more than 90% of adults with a substance use disorder begin their use during adolescence. And so it's important for us to recognize that addiction is indeed a developmental disease. It oftentimes starts in adolescence and childhood. And this is a phenomenon that we as healthcare practitioners are going to encounter quite frequently. But the important part for us to remember, oddly, the majority of children or adolescents and families who are affected go undetected. And this is the issue that we need to keep in mind. There is a rich body of data that outlines the impacts of children who grow up in such families. And each of these bullet points is a study which is referenced from the peer-reviewed literature. But the summation of that data suggests that children who are in these families have higher risks for substance use or substance use disorders in terms of related problems than other children who are in families that are not affected. That oftentimes the family interaction is defined by substance use disorder in the family. It seems to be the primary focus. There's a clearly documented relation between parental substance use disorder and child abuse. And it's been documented in the large proportion of child abuse and neglect cases. There's a higher risk of children being placed outside of the home. These children oftentimes exhibit symptoms of depression and anxiety more than children from non-affected families. In these families, there is a well-documented history of more physical and mental health problems and higher health and welfare costs when problems do exist, as you compare these children to non-affected families. There's a higher rate of behavior problems. These children as a group score lower on tests measuring school achievement and oftentimes exhibit other difficulties in school. There's a long-standing history of maternal substance use during pregnancy and the association with adverse outcomes. But the important part to remember as we look at data on resilience and young people who beat the odds and also very prominent in the literature, is that these are also children who may benefit from supportive adult efforts to help them. So again, if you look at the information that we have from the literature, there are two relevant conclusions that we can come to. One conclusion is that all familial variables that can will affect child outcomes. The second relevant conclusion is that the parent-child interaction is often characterized primarily by two major dimensions, and those dimensions are the importance of nurturance, children receiving warmth and support from a caring adult or family member, and also control, the importance of adequate supervision and appropriate discipline for children as a part of their normal growth and development. So we frequently talk about the opioid epidemic, but most individuals seem to forget that many of the individuals involved in the opioid epidemic are parents, and that many of them also have children. At times, these children are a forgotten population. Many of these children at times are exposed to chaotic family environments that lack consistency, stability, or emotional support. Many will go on to themselves develop alcohol or other drug problems or other serious coping problems. The interesting thing is that most of these individuals will have been seen by their primary care provider multiple times along the way. And as pointed out by the article by Bridget Grant, the number of individuals who are affected, again, defines one of today's major public health problems. So for instance, in a city like Baltimore, where there's a population of some 600,000 individuals, it's represented that there are somewhere in the neighborhood of about 60,000 heroin dependent individuals. Many of these individuals are parents, and many of these are individuals whom are not in treatment. So again, this is an issue of major concern. These are individuals who may encounter poor communication, permissiveness, violence, neglect, under-socialization, all important issues in the health and the well-being of children and adolescents. In addition, if one considers the family and the family disease model, which is a characterization which is frequently used in not only substance use disorders, but in other chronic health disorders, children who live in families affected by substance use disorders may be at an increased risk, both because of genetic, psychological, or environmental factors, and may develop unhealthy living patterns in an attempt to adapt. They may often learn early on to not talk about the family secrets. They may not learn to trust themselves or to trust others. They may not learn how to handle uncomfortable feelings. They may not learn how to build positive relationships. So while genetic predisposition can't be changed, unhealthy living patterns can be countered by consistent caring adults who intervene. Families often tend to act in patterned or predictable ways when there is a chronic illness, substance use disorders just being one example of that. This may include a move away from supportive relationships and a move towards defense mechanisms such as denial, secretiveness, lack of trust, lack of honesty, lack of nurturing behaviors. At times, what is replaced is isolation. Isolation that develops around the family can be both social and emotional, and at times can be rigid and seemingly impermeable in some instances in an attempt to hide the problem. And affected individuals may continue to simply suffer in silence. At times, we consider some of the behaviors that individuals in the family may engage in as enabling behaviors. But health professionals who understand these behaviors can be helpful in uncovering the problem and assisting families with timely and appropriate interventions. And as a result, children in these families can learn to trust, handle their feelings in healthy ways, and can learn to build positive, nurturing relationships.
So we're going to discuss some definitions and terms with regards to treating children that are minoritized. So we're going to look at the iceberg theory of culture. And this is to say that society's culture is like that of a big iceberg in the ocean, with a small percentage that is actually visible above the water, as well as a larger portion that is hidden beneath the surface. So when we view culture and people, i.e. patients, through this lens, we can start to understand why, while we can only see roughly about 10% of a person or a community, we judge, make assumptions, and sometimes clinical recommendations based on the 90% that we can't see below the waterline, as that influences their top 10% that is seen. I'll be coming back to this concept throughout the presentation, as our task is reducing health disparities, is to uncover what lies truly below the surface. Now, we're going to talk about racism and anti-racism, and we'll highlight Dr. Kumara P. Jones and Dr. Ibram Kendi. So Dr. Jones highlights that racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, i.e. their race, that unfairly disadvantages some individuals and communities and saps the strength of the whole society through waste of human resources. And so with that, we have to then think about, well, how is it that we as an individual provider, individual health system can be anti-racist? And Dr. Kendi says that's explicitly expressing the idea that a racial group or groups are equal, actively opposing racism and supporting policies that reduce racial inequity. And we'll come back to the levels of racism later in the presentation. Now, we need to look at the political and legislative history to understand some of the context for the patients that we see today. So looking at this, we're going to start very early in the United States history. And we start with the 1790 Naturalization Act, which made it so that the US citizenship was restricted at that time to free whites. If we even think even a little bit further back, 1619 was the beginning of slavery in the US, with the first 20 Africans brought to Jamestown, VA. But it wasn't until 1808 that the US banned importation of African slaves, but slavery still was legal. While slavery was ongoing and the US wanted to expand, President Andrew Johnson signed the Indian Removal Act, which led to the forced removal of Native American tribes from their lands, and approximately at that time 4,000 Cherokees died on this forced march, which became known as the Trail of Tears. And this is important, as it's one of the most fundamental injustices that have occurred to Native American people that still has a lasting impact today. If we fast forward 250 years after that, the start of slavery in the United States, President Abraham Lincoln signs the Emancipation Proclamation, followed by passing of the 13th Amendment, reportedly abolishing slavery in the US. Now, moving along further, after the abolishment of slavery, Jim Crow laws were enacted in the South. And these Jim Crow laws were quote unquote legal policies and laws that enforce racial segregation. Now, what does this look like? Well, in hospitals, this looked like having colored only units or white only units. And now while this is happening, there are other pieces of legislation that are happening. And so the first one with regards to substances that's important is the Harrison Narcotics Tax Act of 1914. So this was passed to tax and register the import, the sale, and distribution of opium and cocoa derivatives. that was interpreted as a prohibitive act by law enforcement. So again, we see very early that law enforcement begins to play a role in substances. That evolved into being used to actually prosecute physicians who prescribed opioids for the treatment of addiction. It was argued that opioid addiction was not a medical condition, and therefore the use of opioids in such cases was not, quote, in the cure of a physician's, in the course of a physician's professional practice. So the enforcement of the Harrison Act uncoupled, very early, uncoupled addiction and medical practice, leaving drug policy to be fashioned through the lens that stigmatizes and criminalizes individuals in need of treatment, which we still see today. Now, along while the Harrison Act is occurring, we also know that at the same time, there was a Plessy versus Ferguson Supreme Court case that upheld the constitutionality of racial segregation laws for public facilities, as long as these segregated facilities were quote unquote equal in quality, a doctrine that became known as separate but equal. So again, you have these things occurring, and despite separate but equal, we have the Harrison Act. We can start to see how it becomes challenging to have and provide equitable care to patients. Now, moving a little bit further forward in our history, we have then in the 1930s through out the 1950s, the federal government's Home Owners Loan Corporation was created. And that created these city maps that we're going to look at that assigned grades to different neighborhoods. So here's one of those maps, redlining maps. And so what happens here? The Homeowners Loan Corporation created city maps, assigned grades to the residential neighborhoods that reflected their mortgage security. That would be then visualized on these colored maps as you're seeing. And for this particular maps, given that Dr. Adger and I, Dr. Adger's in Baltimore, I'm in Boston, so we use these two maps. Neighborhoods receiving the highest grade were labeled A, colored green on the maps, were deemed of minimal risk for banks, mortgage lenders, and developers when determining who should receive loans and which areas in the cities were safest to invest in. Those receiving the lowest grade, D, colored red, were considered, quote, hazardous. The colors of these hazardous neighborhoods, how the maps got their redlining, became the name redlining, which we still see today in 2021. We're literally drawn around Black neighborhoods, the redlining, Black neighborhoods, as those communities were overwhelmingly receiving D grades. And so again, investment, home ownership is oversaturated for the green areas versus in the D areas, Black, brown communities. And we get to, if we were to spend more time on this, we could highlight disparities in terms of substance use care, in terms of morbidity and mortality. But want to continue moving on forward with the history here. So as we continue to move forward, we're thinking about the redlining maps. We're going to move a little bit forward, and at the same time that these things are happening, there are other areas where we start to see decisions that are made amongst medical institutions that still to this day have impacts. And one of the more notable ones is in 1951, Henrietta Lacks unknowingly donates her cells. I'm not sure donates is the correct word, but unknowingly donates her cells. And till this day, her cells have produced great outcomes for larger society. But it wasn't until many years after the fact that her family came to find out that her cells were being used. And so what I'm highlighting here is how the medical system and therefore our patients may not trust some of the care that we end up providing them. And then we move forward and we're going to see Tuskegee, study of untreated syphilis in Negro men. And that's well known. But again, there are a lot more studies and circumstances where individuals that are Black and brown have worse outcomes and or non-ethical care associated with them. Coming back to drug policy, in 1970, we have the Comprehensive Drug Abuse Prevention and Control Act, which was President Nixon's declare, quote, war on drugs. The drug war was later referred to by one of Nixon's aides as a means to target his political adversaries, namely Black people and the anti-war activists. And as we continue to move forward, we've touched on a number of important historical landmarks in our society, both from a health perspective, drug policy perspective. What I'd like to move forward here is thinking about other things that have happened where reportedly there are policies trying to make life more equitable, but undoubtedly still that tends not to be the case. So as we move forward, we had the lynching of Emmett Till in 1955. Then in the 60s, we have the Civil Rights Act, which was motivated by movements led by Dr. King, Rosa Parks, and these rights still yet till this day have to continue to be fought for, again, to provide equitable care. We have the Voting Rights Act in 1965, and then coming back to drug policy in 1984, roughly 84, 86, 88, there's anti-drug abuse acts and amendments to those acts. And that's now President Ronald Reagan reignited the war on drugs, passing that Comprehensive Control Act. And that established 22 new mandatory minimum sentences for drug-related crimes and is responsible for the currently 100-to-1 sentencing disparity for crack cocaine versus powder cocaine, which led, unfortunately, to a disproportionate longer sentences for Black persons than for white persons. So these last few slides highlighted some of, not exhaustive list, but some of the important historical landmarks with regards to public policy, with regards to drug policy, that still to this day have impact for the patients that we see, even those adolescents that we see that will find their way potentially to our clinics and hospital systems. Thinking about this historical context, Ta-Nehisi Coates cites 250 years of slavery, 90 years of Jim Crow, 60 years of separate but equal, 35 years of racist housing policy. Until we reckon with our compounding moral debts, America will never be whole. And this is important when we think about providing care to patients who are Black and brown, minoritized communities with regards to substance use. Now, thinking about the impact of racism on health, the Institute of Medicine's Committee on Understanding and Eliminating Racial and Ethnic Disparities in Healthcare published Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. And this highlights an important milestone within medicine, highlighting that racism itself and its context actually does contribute to disparities that we see. We then can see more recently in 2009 that the American Academy of Pediatrics provides a white paper highlighting that racism and racial inequity again is true. And in 2019, there is another policy statement for the American Academy of Pediatrics regarding the impact of racism on child and adolescent health that is led by Dr. Trent at Johns Hopkins University, where Dr. Adger works. Thinking about education, because this is highly important, and education's impact on health. So early work on social determinants of health and health disparities consistently discovered that education matters is linked to health outcomes. This occurs by providing increasing income opportunities and resources, including access to healthier neighborhoods, increasing health knowledge and skills, and improving psychosocial factors. Furthermore, it is well documented that there is a preschool to prison pipeline. Black students face disproportionately harsher punishment in school for nonviolent offenses, and or the development of appropriate behavior seems to be suggested to not be equal for Black children, which is not the case. Furthermore, it's well documented that despite Black preschoolers making up roughly around 15 to 18% of preschool population, they represent 48% of those who are suspended once or more times. Similarly, disproportionality is seen with regards to school-related arrests, incarceration of Black youth. Many of these children have learning disabilities or trauma histories and would benefit from additional educational and counseling services instead of punitive outcomes. Instead, they're isolated, punished, and pushed out. This has consequences because we know, and the evidence would suggest that when any student, including Black students, experience suspensions, experience incarceration, they are going to be at a greater risk of engaging in substance use. And we know, as was presented earlier, that for adults who have substance use disorder, 95% began their substance use before the ages of 18. So thinking about the health and delivery of daily lives of minority youth in the US, we have to think that, what we've learned thus far is that minority youth have a different experience than those who are not minority. And so majority of US Black and Latino adolescents as young as 10 years old report experiencing racism and or discrimination, while only 8% have not. So again, the vast majority, by the time they're 10 years old, suggest that they've experienced racism. Additionally, exposure to police violence, such as watching videos of unarmed Black men and teens and women on social media, has been found to have negative effects on their mental health for Black youth. And personally, I find the videos traumatic to watch and stressful. See that I'm getting an increase in my own heart rate right now, just thinking about the videos. Now, keep in mind when we discuss the experiences of our Black patients, the concept of intersectionality, which is when one experiences additional discrimination based on belonging to another disadvantaged group besides race. So for example, I myself am a Black person, I'm a Black male, and that experience colors how I myself walk through the world and interact with people. And so when we're with our patients, we have to think about the intersections that they exist in. Now, this is in reference to the levels of racism, and this comes from an important paper from Dr. Jones, who was highlighted earlier. And so racism itself exists in 3 levels, right? So there is institutionalized racism, and so we can think about zoning policies that we talked about with regards to Black neighborhoods that prevent, let's say grocery stores from being in certain well-developed neighborhoods. Then we can think about personally mediated racism. I think this is the one that most commonly folks think about. But let's just say a doctor tells a family that they need to care about themselves more. They need to care about their health more and stop being lazy, so the patient can, say, lose weight, right? That might be a more personally mediated form of racism. And sometimes it's intentional, sometimes it's unintentional, but that exists. And then there's the internalized racism, and that is that our minoritized patients begin to believe that they may be inherently disadvantaged, that they are lazy, which is not true. But given the institutionalized and the personally mediated racism, it can start to actually become internalized. And so it's important to try to address the care of our patients from all of these levels.
So Dr. Simon has given us a historical context, but I'm going to now go back to the iceberg theory and remember that we can only see roughly 10% or so of all that's going on, and that's the part which is above the surface. But fully 90% of that iceberg is hidden beneath the surface. So when we discuss health outcomes and health disparities, we sometimes only see the statistics or the easily identifiable 10% of that can be seen as health outcomes. But in order to truly address health disparities, we really must dive deep down under the water and uncover everything below the surface. And under the surface of this particular health disparities iceberg is everything we just uncovered, including racism, cycles of obstruction, multiple levels of influence that all contribute to social determinants of health, inequity, and versus equality concepts. This also applies directly to access to addiction services and the differences that we see by race or gender. And this is just a slice of various studies that detail that in greater detail. There's a study looking at buprenorphine treatment, divide by race, ethnicity, and payment. And for those of us who work in the field, we see that there is a distinct difference between populations of color versus others who may be able to take advantage of the modern strategies that we have for buprenorphine treatment. Long-term retention and office-based opioid treatment with buprenorphine. There is a distinct difference between the ability to maintain individuals in treatment that we see with populations of color. If we look at the trends in receipt of buprenorphine and naltrexone for opioid use disorder amongst adolescents and young adults, we see that oftentimes adolescents and young adults are not even afforded the opportunity to engage with treatment environments that offer state-of-the-art treatments. If we look at the publication Receipt of Addiction Treatment After Opioid Overdose amongst Medicaid-enrolled adolescents and young adults, we again see a marked discrepancy in adolescents being able to receive treatment even after being admitted to hospitals after an opioid overdose. And as we'll see, even more distressing is the discrepancy that we see between adolescents of color. And then also the differences that we see in terms of racial, ethnic differences in treatment for substance use disorders amongst adolescents. We will detail this a little further along in the talk. So as we dive deeper into health disparities, the question that we can ask, where do we start? What strategies can we engage in to improve the current state? So again, if we look at diving into health disparities, here's a statement which comes from Ibram Kendi. And what Kendi suggests is that the only way to undo racism is to consistently identify and describe it. And then once we do that, to then dismantle it. So you might say, dismantling racism. Well, how do we do that? And what Kendi describes is a three-pronged process of identifying the issue, describing the issue, and interrupting the issue. And as we look at this, he describes that you first want to identify the social determinants of health and racial inequities that impact a specific patient population. But remember, you have to go deep and think of the various levels of racism and influences that live below the surface of the water. So one may identify an issue with transportation due to where your patient lives. So then you want to describe what is occurring and what those social determinants and inequities are by asking your patients, by creating community advisory boards, or by conducting a needs assessment. In other words, we have to hear from our patients. We have to hear their voices. You may find that it takes your patient 3 bus lines to get to your office because they cannot afford a car. And it's 3 bus lines because they live in a transportation desert. There just simply aren't methods of transportation. In a city like Baltimore, there's a system which is an informal system that individuals refer to as the hack system. You frequently will see patients on the corner moving a finger to hail down a ride. But you have to look at what can we do to interrupt these inequities and biases by creating and revising policies and processes and policies that don't exacerbate inequities, and then also examine our own biases. So for instance, when we create a late policy, we may be disproportionately penalizing our patients of color, and maybe there might be the assumption that our patients just simply don't care about being healthy or don't respect our time as health providers, and that's why they're late. When really there are serious obstacles that make it harder for them to come on time. One of the things that we've recognized in our own clinical practice is that this is one of the examples of a structural barrier that we can do something about. And we've enlisted a Lyft system where we assist patients in receiving reliable transportation to make their clinical visits. But the important thing is for us to recognize that wherever we at, we need to look at what we can do to become an ally within the systems that we work with. What can we do to become an ally within the education system, recognizing its importance? The employment system, undoing issues related to income and wealth disparities. What can we do to modify changes in the physical environment? Are patients even allowed into our physical settings? What can we do to ally with individuals in the social environment, modifications in transportation systems, housing, and even the healthcare system? So when we are doing this work and identifying and describing racism and its effect on health, it's important for us to take all of these things into consideration. But what is important is for us to understand the voices of the individuals who we provide services with. We need to ensure that our patients are being able to be heard, that we are hearing their voices, that we know their thoughts, their opinions, and that we then use these and in the ways that we can exert pressure on our various systems to ensure that the voices of our patients are heard and are part of improving the process. And in many ways, I think this is from the article on the impact of racism on children and adolescents. We can look at racism as an adverse childhood experience and a core social determinant of health that is a driver of health inequities. And the question is, how do we counter these? I'm going to move to another case example to try to illustrate some of the things that Dr. Simon well discussed. And I'm going to share with you a clinical case of a 15-year-old Hispanic young lady who has type 1 diabetes. This is an individual who has had multiple admissions to the hospital for her diabetes care. It's known that this patient has a well-documented history of non-compliance. And this patient comes to our attention through a consultation to the Adolescent Medicine Service. And what the consultation asks is, please talk to this patient about medication compliance and the importance of taking her medications. Now, I'll share with you some of the things that were learned as the individual doing the consultation sat, listened to, heard, and attempted to understand this patient. No one on the ward team that was caring for this patient had taken the opportunity to engage with this patient and to try to figure out who was this patient, what was her world all about, what was it that she needed. Her past medical history was significant for the fact that she was diagnosed with diabetes at the age of 7. This is a patient who had in excess of 10 admissions to the intensive care unit because of what was described as poor medication adherence. There were frequent documented changes in the insulin regimen. The social history was significant to the fact that this is a family that had early on come to the attention of Child Protective Services. There were multiple episodes of involvement with Child Protective Services. And there were concerns about discrepancies that one would see between the home environment and the hospital environment, because oftentimes in the hospital, the patient's glucose was much improved. But if you look at this patient's history, it was found that this patient had been documented to be involved in giving her and administering her own insulin since about the age of 8. There were multiple documented concerns about physical abuse, about potential of sexual abuse. This was a patient who had been in and out of the foster care system. This was a patient who was in survival mode. Patient had had documented episodes of running away. The patient was noted to frequently have been found to be living in abandoned houses. Patient had an episode that was documented where the patient was fighting with the mother, and as a result of this interaction, she was arrested and jailed for a period of time at the age of 15. During the time of her incarceration, her diabetes was well controlled. The patient was not in school. The patient had a history of marijuana use. The patient was sexually active with an older male partner. And the patient had documented episodes in the past of participating in cutting behavior. Interestingly enough, the team did not make any attempt to engage this patient. She was discharged from the hospital without a secure plan for follow-up. What came to our attention approximately 2 weeks after this patient's discharge from the hospital was a headline in the newspaper. And the headline was, "Police are seeking help in identifying an older woman found dead in a vacant house." Now, if you look back on this history, there are a lot of things that Dr. Simon talked about that pop out at us. This was a person of color. She was an adolescent. She had low health literacy. She was engaging in what others referred to as risky behavior. She was poor, marginalized. She had previously been incarcerated. She appeared older than her stated age. She was described in the chart as a hot mess, a train wreck, and she was too complicated of a case. She was someone who had a drug use history. She was a runaway. She was unhealthy. She had previously been involved in the foster care system, and the question was the difficulty of placing someone in a new home. She was engaging in adult behaviors. She came from a family where there was a history of substance use. All of these are issues which people heaped upon this, and they did not see the person who we saw, which was someone who was a delight to interact with and needed assistance. And so what we have to learn to do is that we have to learn to push back on these types of characterizations. We have to learn to dive down deep and to look for what is not oftentimes visible on the surface. This was a tragic outcome that should have been able to be avoided.
So we're going to round out our presentation just highlighting a number of just key studies that encapsulate the things that Dr. Adger and I have been talking about. And so this first one comes from Dr. Cummings and all, that was published in JCAP. So racial and ethnic differences in treatment for substance use disorders among US adolescents. And the summary of this study was that low treatment rates for substance use disorders was found among all adolescents, but then worse for Black and Hispanic patients, having the lowest treatment rates across all racial and ethnic groups. So again, Black and Hispanic patients have the lowest treatment rates for all racial and ethnic groups. This next important paper is explaining the racial and ethnic differences in adolescent substance use treatment completion in the US. And so the reason for that first paper is true is that Black and Hispanic youth were significantly less likely than their whites to complete treatment for both alcohol and marijuana, and completion rates were similar for whites, Native American, and Asian Americans. And so the differences in predictor variables explain 12% of the Black-white alcohol treatment gap and 7% of the cannabis treatment gap. Factors related to social context are likely to be important, so social determinants of health contribute to the white minority differences in treatment completion, particularly for Hispanic youth, Black youth, and increased Medicaid funding coupled with culturally tailored services could be particularly beneficial. Thinking about this next study, that's important, adolescents serving addiction treatment facilities in the US and the availability of medications for opioid use disorder. So this was a cross-sectional study in 2017, looking at the National Survey of Substance Use Treatment Services Facilities as they're classified. And among the more than 13,000 addiction treatment facilities, 26% offered adolescent programming. Adolescent serving facilities were then, so the small percent of facilities that serve adolescents were half as likely to offer maintenance medications for opioid use disorder as adult-focused facilities, which was offered at 23% of the adolescent versus 36% of the adult focus. So again, smaller percentage of addiction treatment facilities service adolescents, and then even a smaller percentage of those that do actually provide medications for substances such as opioid use disorder. And then among the adolescent serving facilities, characteristics associated with increased odds of offering maintenance mod were nonprofit status hospitals, hospital affiliation, accepting private insurance, accreditation, being in the New England area, and having inpatient services. So we can see already there'll be some disparities there, given that accepting private insurance is one of those factors. And in terms of receipt of addiction treatment after opioid overdose among Medicaid enrolled adolescents and young adults, this is another important paper. This is a retrospective cohort study looking from 2009 to 2015. And Medicaid enrolled youth 13 to 22, 26% of that population had a heroin overdose, 74% had some other opioid overdose. And of the roughly 3,500 more with the opioid overdose and enrollment in a longer than 30-day after the overdose, 68% received no addiction treatment. 68% again received no addiction treatment. This is after an opioid overdose. And only 29.3% received behavioral health services. And only 1.9% received some kind of pharmacotherapy. Again, this is after opioid overdose. So we're going to see that there was a marked racial ethnic disparity. Only one Black or Hispanic youth in the study received pharmacotherapy of more than 3,000 individual cases. And looking at health disparities in this population from a 12-year longitudinal study that was done in 2016. So again, the objectives of this was to examine sex and racial ethnic disparities in the prevalence of the 9 different substance use disorders over a 12-year period. And this was looking at a juvenile project, a prospective longitudinal. So again, over 1,000 youth that were sampled for detention in Chicago, Illinois, starting in 1995, and re-interviewed up to 9 times in the community correctional facility through 2011. Median age was 28 years old. Overwhelmingly were male. And then at most follow-ups, males had a greater odds of alcohol and or cannabis use. Substance use disorder were most prevalent among non-Hispanic whites, followed by Hispanics, then African Americans. Compared with African Americans, non-Hispanic whites had a 32 times the odds of cocaine use disorder. And the findings include that substance use is a significant problem, as we've been highlighting, amongst those in juvenile justice service or in justice services. Irrespective of sex or race, ethnicity, substance use disorders are the most common psychiatric disorder among delinquent youth, those that are engaged in juvenile services. After detention, substance use disorder presents as a continuing challenge for the community mental health system. And so what's the implication? We need to address as a health disparity, the disproportionate incarceration of African Americans for drug offenses. We need to acknowledge that substance use disorder has a far greater consequence for racial and ethnic minorities. And we need to highlight that the need to improve prevention intervention services for during incarceration and after is highly important. So we need to develop these systems more robustly. And so thinking about all these areas, there's important article from Pamela Wall at Morehouse School of Medicine. Many rivers to cross, critical challenges and overarching goals for the African American Behavioral Health Center for Excellence. And so there are 4 tenets, in particular areas of challenge that stand out. And we agree is systemic inequities that block many minoritized populations from sufficient access and engagement in evidence-based treatment. We highlight studies that showed that scarcity and insufficient use of culturally appropriate evidence-based and promising interventions for patients of color. There is a minimal workforce development for mental health clinicians on the social determinants of health and subjects such as implicit bias, cultural humility, and factors that impede high quality care for minoritized populations. And 4, the difficulty of reaching the full range of providers with the training and resources needed to address the variety of circumstances and challenges affecting this highly diverse population. So we need to attack this from all fronts with regards to getting our patients the best care. So practical issue, what is our role as a healthcare profession and healthcare professionals with regards to child health advocacy? So, in addition to being in the clinic, in addition to doing studies, we need to be politically motivated and advocate as best as possible with regards to our patients. And we saw that this happened in the summer of 2020 regarding all of the lives that were lost at the hands of violence. And so we as a system have to wear our white coats, not only in the clinic, but also in the street, and also advocating in political arenas. And so, this is a long presentation highlighting a lot of the challenges related to substance use treatment and substance use for adolescents of color. But take home is that drug use is a preventable behavior, and that drug addiction is a treatable disease. And we are more than capable as a system of providing equitable care, providing equitable access, and evidence-based, culture-informed care. We just have to do the work, and it's important that we do this. And so, we thank you for participating. And these are the references that are highlighted throughout the paper that you will have access to. And we thank you with regards to being attentive during this important presentation.
I want to thank you again to our presenters today, Dr. Simon and Dr. Adger. You can access the links to the slides from today's presentation and the on-demand recording on the EMRSA, ATTC, and NORC websites. To augment the information provided today, you can check out these additional resources from the ATTC and PTTC networks. You can also keep in touch with ATTC, NORC, and EMRSA via their newsletters and social media. Sign up now for monthly emails and follow them on Twitter and Facebook. And with that, we thank you so much for attending, and this concludes today's webinar. We hope you will view all of the episodes in this Transitional Age Youth series. Thank you.